So in that last lecture, that was quite a bit of physiology. Most lectures will not contain that much, with the assumption that you've already learned the physiology and the pathophysiology last semester. However, because it's much easier to understand the drugs when you have an excellent and thorough grasp of the physiology of the autonomic nervous system, we really did need to hit some of those major high points before moving on to the drugs. So now that we've done that, let's move on to the pharmacology. So we will be using the prototype approach to discussing these drugs. What that means is that you won't remember or memorize every drug in the drug class. Rather, we'll use one or in some instances two prototypes that will be representative of all the drugs in that class. And the idea is that if you understand the prototype well, you will be able to take that knowledge and apply it to the rest of the drugs in that class when you're working as a student nurse or as a nurse administering those medications. Now, as I said, we'll usually have one prototype, but on occasion, we will present more than one drug in a class. And we do that when there is a very important difference with one of those drugs, or when there are kind of subdivisions within a class. For example, some drugs are selective at a receptor site, while other drugs in that class may be non-selective at receptor sites. So in that scenario, we would discuss two prototypes for that particular class. But really, the important point is that for that second group, we'll be highlighting what is specifically different, what's important, what stands out that differentiates those two drugs within that class. We also will occasionally provide a name recognition slide. So when drugs in a class are named similarly, meaning they have suffixes that identify the drugs as belonging to a particular class, we will discuss that as well. And again, that is really to benefit you when you're working as a student nurse or when you're working after nursing school. So when you encounter these drugs you haven't heard of before, you'll recognize the naming convention, and you'll be able to place that drug within the appropriate class, and you'll know the pharmacology of that general class. So we think it'll be a really helpful thing for you. Okay, so that's just the background information. Let's actually talk about the drugs. And we're going to start with the cholinergic drugs. So the cholinergic drugs fall into essentially four categories. The cholinergic drugs are agents that influence the activity of cholinergic receptors. Most of these drugs act directly at the muscarinic cholinergic receptors. And so all of you should be thinking right now, wait a minute, where are the muscarinic receptors? Where are they located? So maybe pause the tape if you want and think through that physiology. But if you pause the tape, or if you're just kind of listening through, hopefully you recognize that muscarinic cholinergic receptors are in the parasympathetic nervous system. So when we talk about the muscarinic agonists or antagonists, we would expect agonists, the responses that we see from muscarinic agonists, would be similar to activation of the parasympathetic nervous system, whereas muscarinic antagonists would be similar to blocking the parasympathetic nervous system. The others that we'll discuss are the cholinesterase inhibitors. The cholinesterase inhibitors influence cholinergic receptors indirectly because they prevent the breakdown of acetylcholine. So we'll talk more about those. And then finally, we will conclude our discussion of cholinergic drugs by reviewing the neuromuscular blocking agents. Technically, these drugs are cholinergic since they act at the motor end plate on skeletal muscle, and the neurotransmitter is acetylcholine. So remember, acetylcholine means that the receptors that accept acetylcholine are considered cholinergic receptors. Now, in practice, we don't refer to the neuromuscular blocking agents as cholinergic. However, they technically are cholinergics. We just call them neuromuscular blocking agents, or we also call them paralytics. So we'll conclude our discussion of cholinergic drugs by reviewing those. But let's start off by talking about the muscarinic agonists. So our prototype muscarinic agonist is bethanechol. The brand name is uricoline. So you can see on the slide, I have the drug name, and then in parentheses, that is the trade name, and all of our slides will include the trade name. In some instances, the drug might have been around for such a long time that there is no trade name or brand name at this point, so in that case, we would not include it. So Bethanechol is our prototype. By the way, to determine our prototypes, we review the textbook. We also review the NCLEX testing resources to determine what they consider as the prototype for each drug class. For the muscarinic agonist, Bethanechol is the prototype. This drug acts by directly stimulating muscarinic receptors. Now, this particular muscarinic agonist, Bethanechol, is more selective for the muscarinic receptors in the GI tract and the bladder, as opposed to muscarinic receptors that are located in other places. So, as I said when we talked about the physiology, if you understand which receptors and the location of those receptors, if you understand what the drug is doing, is it an agonist or an antagonist? So in this case, this drug is an agonist. So it's a muscarinic agonist. That means we're going to activate the parasympathetic nervous system. And remember, the parasympathetic nervous system is interested in all of the housekeeping functions of the body. So for this particular drug, when these receptors are activated, specifically those in the GI tract, we increase GI motility. And that makes sense because from a housekeeping perspective, we want to be able to digest our food and to absorb nutrients from our food. So this particular drug is used to increase GI motility. And these receptors are also distributed in the bladder. So this drug could be used to treat urinary retention as well. And so when muscarinic receptors in the bladder are activated, this causes relaxation of the trigone and the sphincter muscles, and this will increase voiding pressure by contracting the detrusor muscle. So ultimately, it causes urination. Generally, this medication, when used for that therapeutic use, would be in post-op or postpartum patients, and usually it works pretty quickly. So, as I mentioned, the drug could be used for GI motility, but really the primary use for this drug is for treatment of urinary retention. Some adverse effects that can occur: hypotension, bradycardia, excessive GI secretions, asthma exacerbation. These are all things that make sense. If you know what happens when you activate the parasympathetic nervous system, these are some of the side effects of the drug, but also effects that we would see when the parasympathetic nervous system is activated. Nursing implications, so the drug can be administered with food because it can cause nausea and vomiting, and so giving it with food can decrease that. And also, so I have in italics, when this drug is used for urinary retention, there needs to be a bedpan immediately available because the drug will induce urination pretty rapidly and profoundly. So some medication safety concerns of note with this medication. So muscarinic agonists in either high doses or in an overdose situation can cause toxicity. And basically this is because of over excitation of the parasympathetic nervous system. And so symptoms: profuse salivation, lacrimation, visual disturbances, bronchospasm, diarrhea, bradycardia, hypotension. Again, these are all just extreme effects of the parasympathetic nervous system. It's kind of like the rest and digest system on overload. And because of the potential effects on the lungs and on the heart in terms of bronchospasm, bradycardia, and hypotension, in an overdose situation, these drugs can be very toxic. They can actually lead to cardiovascular collapse. And so the treatment in the situation of an overdose of Bethanechol or another muscarinic agonist is to basically treat with a muscarinic antagonist. Our prototype muscarinic antagonist is atropine, and we'll discuss the pharmacology of that medication in a moment, but essentially it's blocking the cholinergic receptors. So if you have too much bethanechol on board, then the atropine is competing for those receptor sites, and it's decreasing the likelihood that bethanechol will be able to activate those receptor sites and cause those extreme effects of the parasympathetic system. Essentially, we consider atropine to be a reversal agent because it can potentially reverse that toxicity. So moving on to the next class, we have the muscarinic antagonists. Muscarinic antagonists, by the way, these are also called anticholinergic. This drug class is extremely important. All of the drug classes that we talk about in this autonomic nervous system lecture, I would say, are important. They're all drugs that you most likely will see, maybe with the exception of bethanechol, but a lot of the other drugs we talk about you will see in practice. Of all of the drugs, this one is right up there at the top of the list. The prototype I said is atropine. The drug acts by competitively blocking muscarinic receptors. So essentially that prevents acetylcholine and other muscarinic agonists from binding to those receptors, and that prevents that therapeutic response. So when you think about how these work and what response you would see, and what they would be used for, what you need to do is just think back to your parasympathetic nervous system and think that these drugs will do the opposite, right? So you know what happens when you activate that system. Essentially, atropine and other drugs like atropine will produce the opposite effects. So these drugs are used to dilate pupils for eye exams, to treat bradycardia. Remember, muscarinic agonists cause bradycardia, so these drugs can reverse bradycardia. They are used, as I already mentioned, for muscarinic agonist overdose or poisonings. There are some natural substances that can activate muscarinic receptors. For example, certain types of poisonous mushrooms can activate muscarinic receptors. So in that setting, atropine could be used as a reversal agent or antidote for those poisonings. And they also can be used as a pre-anesthetic agent. So these drugs have adverse effects that are predictable. Again, if you know what happens when you block parasympathetic receptors, then you can imagine you can figure out what your adverse effects would be. You have to know these. Anticholinergic side effects are important to know for a variety of reasons. One, because anticholinergic drugs are prescribed pretty commonly, and not just the drugs that fall kind of exclusively in the anticholinergic drug class, but we'll talk about several other drug classes throughout the course that the drug might be, for example, a tricyclic antidepressant. So it's an antidepressant drug, but the drug is also capable of blocking cholinergic receptors. And so drugs like that are said to have anticholinergic side effects. So those anticholinergic side effects: dry eyes, dry mouth, blurred vision, constipation, and urinary retention. You absolutely need to memorize those and be familiar with those. Like I said, there are a lot of other drug classes like the tricyclic antidepressants, the antihistamines, the antipsychotics. These drugs can also block cholinergic receptors and also will have a very similar side effect profile. In terms of nursing implications, especially for these adverse effects, because they can be very problemsome for patients, it's important to provide patient education for patients to help them avoid some of these problemsome side effects. So for example, dry mouth is pretty common with the anticholinergic drugs, and it's pretty common with some of those other drug classes like antihistamines, for example, or Benadryl. Maybe some of you have had allergies and you've needed to take Benadryl in the past. One of the biggest complaints for Benadryl, aside from sedation, one of the biggest complaints people have is that it causes dry mouth. So you can tell patients to drink a lot of water. That can be helpful. Or you can tell them to suck on like a sugar-free candy, for example, and that can help the patient overcome the dry mouth. So let's review some medication safety concerns with the anticholinergic drugs. I think you'll find or you'll recognize that for all of the drugs that affect the autonomic nervous system, whether they affect the cholinergic or the adrenergic systems, in excess or overdose situations, they can be toxic. And I think that probably makes a lot of sense to you guys because in an overdose situation or with very high or excessive doses, essentially we're pushing these physiologic systems to the brink. And so we do worry considerably about excess or overdose situations with these drugs. So the anticholinergics are no different, of course. So with the anticholinergics, um, I already mentioned some of the symptoms, and we have a saying that goes along with these symptoms. And the saying is, mad as a hatter, dry as a bone, blind as a bat, red as a beet, or hot as a hare. You may have heard this saying before. Maybe even you learned it in pharmacology. Maybe not. But when we think about the anticholinergics, we usually think of that mnemonic to describe the symptoms that the patient might be experiencing. So mad as a hatter, that's because these drugs in an excess or overdose can cause psychosis or even seizures. Dry as a bone, remember, if you're blocking the parasympathetic nervous system, then you're blocking all of these different secretions that we would normally need for the rest and digest process. Because remember, anticholinergic is the opposite of rest and digest. So we see that secretions are decreased. We see dry mouth, dry skin. Essentially, we've got decreased salivation, lacrimation, urination, defecation, sweating. All of these things kind of dry up. That's why we call it dry as a bone. Blind as a bat, because the eye is controlled by both, the parasympathetic and the sympathetic system. The eye can't accommodate in an overdose situation, so we can't see close up. The pupils can't constrict. Patients can experience photophobia. Red as a beet, we have cutaneous blood vessels that dilate as a response to some of the other problems that are going on with anticholinergic excess. And because of that cutaneous blood vessel dilation, the skin feels warm, and so that's why we say hot as a hare. I will post that mnemonic on the discussion board so you guys have it. I think it's a great way to remember those symptoms. It's also in your pathophysiology section of these slides, so you could refer to it there as well. So treatment. In terms of reversing anticholinergic excess, we can use activated charcoal. So if it's a drug that is being absorbed from the GI tract and the patient recently took it, we could potentially use activated charcoal. Or we could use physostigmine. I'm going to talk about physostigmine in a moment when I talk about acetylcholinesterase inhibitors. Essentially, physostigmine just increases the amount of acetylcholine at the receptor sites. And so you've got your anticholinergic drug that's blocking those receptors, and if we dramatically increase the amount of acetylcholine that's at the receptors, then it's more likely that the acetylcholine will be able to bind to those receptors and cause a therapeutic response, essentially reversing the effects of the anticholinergic. We do need to, or I do need to mention a warning. So sometimes because these patients may have the mad as a hatter symptoms, psychosis in particular, sometimes patients that have anticholinergic excess are thought to be having a psychotic break when in actuality they've had an overdose of their anticholinergic. So what we do is we look at those psychotic symptoms and we take those kind of as a full picture. Is the patient experiencing other anticholinergic symptoms that would differentiate this from just a psychotic break or a psychotic episode as compared to an overdose of an anticholinergic agent? Finally, the last thing I want to mention is that anticholinergics do appear on the Beers list. And we talked about the Beers list when we talked about individual variation. And so why don't you pause for a minute and think, when is the Beers list applicable? What patient population is the Beers list concerning for? So hopefully you identified that geriatric patients. So the Beers list is specifically formulated for concern over use of these medications in the elderly population. So we do worry about anticholinergics. The elderly population can be more sensitive to the effects of anticholinergic drugs, and so we do try to avoid these drugs in the elderly population. Or, we might use lower starting doses, might monitor those patients a little more closely if they do need to use an anticholinergic agent. Okay, so that concludes our discussion of the muscarinic agonists and antagonists. So let's move on and talk about the cholinesterase inhibitors. Cholinesterase inhibitors really can be a little bit confusing because they have both nicotinic and muscarinic effects. Because they don't act directly at a specific receptor site, but rather they just increase the amount of acetylcholine at the various receptor sites. Because of that, they can technically activate either nicotinic receptors or muscarinic receptors. Because they increase the amount of acetylcholine at those receptors, and then that means that there's more acetylcholine around to activate those receptors. So kind of in essence, they're nicotinic and muscarinic agonists. If you think about it, in essence, that's kind of the activity that they have. But if you specifically look at their mechanism of action, they reversibly block the action of acetylcholinesterase, which is an enzyme that breaks down acetylcholine. So if you block the action of that enzyme, that means you're going to have more acetylcholine at those receptor sites. They do have limited therapeutic uses. Because they act so generally, they have a limited therapeutic uses. One use is myasthenia gravis. I'll talk about exactly what myasthenia gravis is in a moment. They also are used for reversal of non-depolarizing neuromuscular blockade. Remember, non-depolarizing neuromuscular blockers, the prototype drug was pancuronium. There are also depolarizing neuromuscular blockers. There's only one of those, and that is succinylcholine. These drugs are not used to reverse the effects of succinylcholine. They actually potentiate the effects of succinylcholine. All right, so adverse effects that you might expect. So remember, they act at both muscarinic and nicotinic receptors. So your typical muscarinic effects: nausea, diarrhea, increased salivation, bronchial secretions, bronchoconstriction. These are all things that you might expect to see when you activate muscarinic receptors. Nicotinic effects that you could see: muscle cramps. You generally don't see full-on muscle paralysis because of the way these are used and the doses that they're used. But that's the typical adverse effects you might see. Drug-drug interactions, clearly competitive neuromuscular blockers. I already mentioned your depolarizing, another name for competitive neuromuscular blockers, depolarizing neuromuscular blockers. So succinylcholine is a major drug interaction. And then your anticholinergic drugs are another action, because they're going to oppose the effects of these drugs. I think one of the most important nursing implications for acetylcholinesterase inhibitors is patient education, specifically for myasthenia gravis patients, because these are the patients that are going to be using the drug kind of out in the community. These patients have to be able to recognize extreme side effects, and I'll talk about what those extreme side effects are in a moment. All right, so before I go any further, I do need to just quickly talk about myasthenia gravis, because this is really the main indication for these drugs, and I just want to make sure that you guys understand what myasthenia gravis is. Myasthenia gravis is basically an autoimmune disorder, causes kind of fluctuating muscle weakness, rapid fatigue, and it's really as a result of an autoimmune process where antibodies attack the nicotinic receptors on the motor end plate. And basically, the acetylcholinesterase inhibitors, when we use those for myasthenia gravis, so if you look at the diagram on the screen or the picture on the screen, those little Y's are the antibodies, and they're basically blocking your acetylcholine from getting onto the receptor. So when we use cholinesterase inhibitors, it just increases the amount of acetylcholine at the receptor site, and it allows a more prolonged effect of acetylcholine. And essentially, from a disease standpoint, this intensified effect of acetylcholine increases muscle strength. And for myasthenia gravis patients, that's important because their main issue is muscle weakness and fatigue. So really, cholinesterase inhibitors, all they really do is provide symptomatic relief. That's essentially what they do. Okay, so in reference to some medication safety concerns with your cholinesterase inhibitors, I did mention that you can have extreme symptoms from overdose or excessive exposure to anticholinesterase inhibitors, and that excessive muscarinic stimulation it can be a major issue and can also cause respiratory depression. So an easy way to remember this is sludge and the killer bees. It's just another mnemonic kind of saying to help you remember. Sludge is salivation, lacrimation, diaphoresis, diarrhea, GI cramping, emesis, bradycardia, bronchospasm, and bronchorrhea. These are all really severe. These are severe effects of overdose of the cholinesterase inhibitors. Treatment would be with atropine, which is a muscarinic blocker, so that makes sense that it would counteract some of those extreme muscarinic stimulation effects. The muscarinic effects, like I just mentioned, those can be prevented with atropine, but the mechanical ventilation and the suction part, specifically the mechanical ventilation, is used to reverse the respiratory depression and counteract the effects at the motor end plate, causing muscle weakness or even paralysis. So finally, let's conclude our discussion of cholinergic drugs by reviewing the neuromuscular blocking agents. Remember, technically these are classified as cholinergic drugs, although in practice we generally don't refer to them as cholinergic drugs. Usually you'll hear these referred to as paralytics. Hopefully you remember that neuromuscular blocking agents act at the motor end plate. These are part of the somatic nervous system and they control voluntary movements. So when I start to talk about the actual drugs, it'll make sense to you why they work the way they do. So there are two types of neuromuscular blocking agents. There are non-depolarizing and depolarizing neuromuscular blocking agents. First, I'm going to talk about non-depolarizing neuromuscular blocking agents. The prototype drug here is pancuronium. The mechanism of action of pancuronium is that it competitively blocks the action of acetylcholine at the neuromuscular junction. And remember, that's part of the somatic nervous system that causes voluntary movements. So the therapeutic use, these make perfect sense, would be an adjunct to general anesthesia, right? So you've got a patient anesthetized and you don't want them to move. Mechanically ventilated patients, so you have a breathing tube in your patient and you don't want them to move and dislodge the breathing tube. And also intubation, so facilitating the process of mechanically ventilating a patient will paralyze the muscles to help facilitate that process. In terms of adverse events or adverse effects, respiratory arrest, obviously if you give a patient a neuromuscular blocker and you don't provide them mechanical ventilation, they will go into respiratory arrest. That is why these drugs are so scary, because if they're used by mistake, if you give a neuromuscular blocker to a patient who's not mechanically ventilated or in the process of becoming mechanically ventilated, they will stop breathing because it will paralyze their diaphragm and they will stop moving air in and out of their lungs. And that is obviously very serious. They can also cause electrolyte disturbances, so that's something to keep in mind as well. Some drug-drug interactions of note: general anesthetics, antibiotics, not all antibiotics, just some antibiotics, and cholinesterase inhibitors, which we will talk about soon. These can all potentiate the effects of non-depolarizing neuromuscular blocking agents. Not cholinesterase inhibitors. General anesthetics and antibiotics can potentiate the effects. Cholinesterase inhibitors actually inhibit the effects of neuromuscular blocking agents. Individual variation in drug response. So I want to point out that there are several different non-depolarizing neuromuscular blocking agents on the market, and they vary in their methods of metabolism and excretion. Some of these drugs are renally excreted. Some of them are extensively metabolized and excreted via the hepatic system. So if your patient has significant renal dysfunction, some of these agents won't be appropriate. If your patient has extensive hepatic dysfunction, some of these agents won't be appropriate. It's really important to remember when you're dealing with these drugs that you have to have a good grasp on your patient's renal or hepatic dysfunction, and make sure that the drug that's being administered to your patient is being administered appropriately based on that individual variation. These drugs can also cause problems for patients with myasthenia gravis, and we'll talk about that disease state in a few moments. The effects of these drugs can be reversed by cholinesterase inhibitors, and I will talk about the mechanism of action of cholinesterase inhibitors in a few moments, and it'll make sense why these could be used for the reversal of neuromuscular blockade. Name recognition slide. So as I mentioned previously, there are some drugs that are all named similarly. When they're in the same class, they're all named similarly. So the non-depolarizing neuromuscular blockers are all named similarly. Their ending is either rhonium or curium. So if you see either of those two endings on a drug name, know that it's a neuromuscular blocking agent. And remember, whenever in practice you encounter a neuromuscular blocking agent, you have to be extremely careful. These drugs can be very deadly for patients that aren't appropriately mechanically ventilated. So keep that in mind. This is just a picture of some of the products that you might encounter. You can see the 4 on the left: vecuronium, cisatracurium, pancuronium, rocuronium. Those are all of our non-depolarizing neuromuscular blockers, and then the one on the right, succinylcholine. Now, for our purposes, you only need to know 2 of these, right? Pancuronium is our prototype non-depolarizing neuromuscular blocker, and then the one on the far right, succinylcholine, is our prototype for the depolarizing neuromuscular blocker group. All right, so let's talk about the depolarizing neuromuscular blocking agent. There's only one drug of this type on the market, thus it's our prototype, and it's called succinylcholine. This drug's been around for a really long time. Frankly, there's not even really a brand name for this drug at this point. Everyone just calls it succinylcholine. The mechanism of action, it depolarizes the muscle fiber, preventing the action of acetylcholine at the neuromuscular junction. So it acts a little bit different from the non-depolarizing neuromuscular blocking agents. This actually activates the receptor, but it activates it in such a way that it doesn't produce the same response that acetylcholine would produce. But since it does depolarize the muscle, it prevents acetylcholine from depolarizing the muscle and causing a response. The therapeutic use really is limited to endotracheal intubation. That's really the primary use for this drug. It's pretty short acting. So some of the other uses that we saw for non-depolarizing neuromuscular blocking agents would not be therapeutic uses for succinylcholine. Adverse events, some very similar to the non-depolarizing neuromuscular blockers, such as respiratory arrest. Again, obviously, if the patient's not mechanically ventilated and they receive this drug, they're not going to be able to breathe on their own, and they could go into respiratory arrest if they don't ultimately receive mechanical ventilation. But some other adverse events specifically associated with succinylcholine: hyperkalemia. Hyperkalemia results because succinylcholine promotes the release of potassium from cells, and this can result in severe hyperkalemia and ultimately cardiac arrest. Not for all patients. It's most worrisome for patients that have extensive burns, have head trauma, or other conditions such as denervation of skeletal muscle or upper motor neuron injury. These patients should not receive succinylcholine. It also can cause post-op muscle pain. About 10 to 70% of patients experience this, so you want to explain to your patients and basically make them aware of the fact that they could be experiencing muscle pain for anywhere from maybe 10 hours to maybe 24 hours or so after their after their operation.
It can also cause malignant hyperthermia. This is a very serious condition that can be fatal. It's rare, potentially fatal condition, could be triggered by succinylcholine, causes muscle rigidity associated with a profound elevation of body temperature. Overall, patients can experience cardiac dysrhythmias, unstable blood pressure, electrolyte derangements, metabolic acidosis. If this is not treated, the condition will rapidly prove fatal. So this is very, very serious condition, and it's really has a genetic basis to it. The treatment of malignant hyperthermia includes immediate discontinuation of succinylcholine. So if the patient begins to experience malignant hyperthermia, you stop succinylcholine right away. The patient is cooled with external ice packs and intravenous infusion of cold saline. There's a drug that we can use to treat this called dantrolene, which stops heat generation by acting directly on skeletal muscle to reduce its metabolic activity. So there is a treatment for this, but it's very important that this is recognized quickly. So if you work in the OR or you work in the ICU, this is something that you would be trained to recognize. Individual variation that you should be familiar with succinylcholine. It is contraindicated in patients with low pseudocholinesterase activity. That's just the enzyme that breaks down succinylcholine. And there is, this is due to genetic factors that cause that. If a patient's suspected of having low pseudocholinesterase activity, then they should be tested before they receive succinylcholine. Cholinesterase inhibitors, just so you know, do not reverse the effects of the depolarizing neuromuscular blocking agents. You may remember from the last slide that I said cholinesterase inhibitors can be used to reverse the effects of non-depolarizing neuromuscular blockers like pancuronium. However, they do not reverse the effects of of depolarizing neuromuscular blockers. Rather, they potentiate the effects. And that's because acetylcholinesterase, the cholinesterase inhibitors affect acetylcholinesterase. And when you decrease the activity of the cholinesterase, this increases the activity of succinylcholine, and that's really how the effects of succinylcholine are potentiated by cholinesterase inhibitors. So what I want you to know is that succinylcholine cannot be reversed by cholinesterase inhibitors. You should not give cholinesterase inhibitors to reverse this effect because, in fact, it will actually potentiate the effect. So some medication safety concerns with neuromuscular blockers overall, both depolarizing and non-depolarizing neuromuscular blockers. I've already mentioned that these medications are high alert medications. All of you as nurses in training, and ultimately you'll be registered nurses, you absolutely, without a doubt, have to know your high alert medications. We're going to talk more about high alert medications on Wednesday, which is lesson 5. At this point, what I want you to know is that neuromuscular blockers are considered high alert medications. The reason why is because there are numerous cases of accidental administration leading to respiratory arrest and almost in all cases death. I personally think one of the worst things about this particular type of medication error is that generally the patient is fully alert and conscious. Neuromuscular blockers paralyze muscles. They do nothing to affect consciousness. So patients can feel pain. They're perfectly conscious in many cases. They're fully alert, and they want to breathe, but they just can't. Not only can they not breathe because you've paralyzed their diaphragm, but they also can't move their mouth and say anything. They can't flail their arms around and say, hey, I'm not breathing. They just lay there still and basically suffocate. So this is just a horrendous medication error for this to occur. So I want you guys to be really familiar with these drugs. Know that that's a potential side effect or a potential adverse effect. And, in practice, handle these drugs with just the absolute utmost care. Use is generally, because of the fact that these drugs can lead to death if they're used incorrectly, use is generally restricted to the ICU, the OR, or the emergency department. Or if the hospital, like all hospitals nowadays, have a code team or a rapid response team that responds to medical emergencies, they will bring the drug with them. But this drug would generally not be stored on general care units or in clinics, where it just really would just add to the potential that it could be used incorrectly, when, for the most part, it would not be needed in those environments. All right, let's move on to cholinergic drugs. Cholinesterase inhibitors.
I think another really important safety measure I wanted to point out to you guys is that these drugs, by FDA ruling, all have to say paralyzing agent on the cap of the product. So you can see these are all different neuromuscular blockers I have pictured here. They have to say paralyzing agent across the top of the cap, and when the cap is removed, they also may say paralyzing agent on the actual top of the vial. They may or may not, but they have to say paralyzing agent on the top of the cap. And the idea is that if you grab one of these accidentally and you see paralyzing agent, that will stop you. Obviously, if you're not trying to paralyze your patient, then that will stop you from administering that incorrectly. So, when you see these kind of warnings in your practice, definitely stop and read them, because that could be the difference between life and death for a patient. Some other quick safety information I wanted to provide to you. So the ISMP is the Institute for Safe Medication Practices. They have a great website. It's ismp.org. All kinds of great information about the way things go wrong with medications. One of the things that they've been doing for the last few years are compiling their best practices for hospitals. And so neuromuscular blockers are included in their best practices for hospitals. So their best practice number 7 says that neuromuscular blockers must be segregated, sequestered, and differentiated from other medications wherever they are stored in the organization. So that means within the pharmacy, however they're stored, they need to be stored separately from other products, and they need to be segregated and sequestered. And what that implies is that these products are stored away from other items, and that they need to be differentiated. And so generally the differentiation is usually via labeling systems. So I'll show you a couple pictures of what that could look like. But here's why. Before I show you what that could look like, here's why. If you look at this bin, this is real. This is a real picture. On the right side, you can see, in the back, you see Nimbex. But what you see in the front is Novolog. Novolog is a type of insulin. If these two products got mixed up, that could have devastating consequences for the patient. So this is generally what you see in practice, both in the pharmacy as well as on the nursing units where these would be stocked. And by the way, like I mentioned already, these are only going to be stocked in areas where they're needed. So the OR, ICUs, possibly the emergency department. But they'll be in these special bins that have a lid, and it'll say very clearly, warning, this is a paralytic agent.
Okay, so that is the end of our lecture today. And hopefully this was helpful. If you have questions, please post them to the discussion board, and we will be monitoring that. Thank you for listening.